Hello, this is Dr. Jeffrey Miller from Baltimore, Maryland. My topic today is From 6 Keys to 6 Month Smiles. What happened? My name is Jeffrey Miller. I graduated from Towson University, received my dental education at University of Maryland, my orthodontic certificate at SUNY Buffalo, my board certification in 1991. I've been in private practice in Maryland for over 35 years. I'm a member of a Golden Circle of Excellence through 3M, and I speak on cone beam CT topics related to the treatment planning and diagnosis of our orthodontic patients. So what happened? How did we go from Andrew's 6 keys of normal occlusion to 6 month smiles, or systems similar to 6 month smiles? I realize that most orthodontists don't use 6 month smiles. It's mainly a system for general dentists. But how did we get there? And believe me, there are systems that are very, very similar to the 6 month smiles that orthodontists do use. So what happened? Well, I think, unfortunately, there's been a general dumbing down of orthodontics. And in this short video, I'm going to present a couple maybe explanations for that. Just aside, when you look at this 6 month smile ad, and you see that the 6 month smiles providers love using these 3 cases. They're all over the internet, and you look at them, and first thing jumps out at me is there appears to be tissue dehiscence associated with the lower incisor on this case, and in this case the case was finished in crossbite. And these are cases that they're proud of. These are their gallery cases. And I'm not sure what that represents, but I can imagine everybody has an opinion regarding that. I talk to orthodontists from all over the world, and one thing I continue to hear is that orthodontists have lost their ability for critical thinking. I actually don't believe this. I don't agree with that. I think orthodontists are some of the smartest people on the planet, and they actually are critical thinkers. So what happened? Well, I think a lot of it has to do with aligners. Aligners, if you think about it, have reduced orthodontics to the mechanical alignment of only the clinical crowns for a lot of providers. I'm not saying everybody treats aligners this way, but for a lot of providers, it's all about aligning the clinical crowns with really no regard to what's happening underneath the tissue. And when we see these virtual simulations, this is a virtual simulation. The gingival tissue on the virtual simulation is just painted on there. There's really not much connection between the gingival tissue modeling and reality. Really, all you're doing is aligning these clinical crowns. There's really no consideration for the position of the roots, nor the underlying bone that supports those teeth. You'd be surprised of how many orthodontic providers just click the accept button when they're ordering aligners with no modification. And I found that most of these cases need significant modification. I think part of the story can go back to bonded lingual retainers, or the popularity of these things. When orthodontists use bonded lingual retainers, the stability debate, or long-term stability debate, is minimized. You generally don't go to a conference and hear speakers talking about long-term stability as much as you used to. And that's probably because you can violate a lot of orthodontic principles, put a bonded lingual fixed retainer in, and the case may hold up, or at least the teeth won't shift. There may be other consequences, but the teeth may stay aligned. But I think one of the bigger problems is that I believe that cephalometrics is an outdated diagnostic tool when you compare it with cone beam CT. You're looking at a wide focal trough with many superimposed structures. You're not looking at individual teeth, and you're attempting to trace or relate the positions of the teeth to statistical norms based on whatever analysis that you like. And I think that really when you start comparing cone beam CT to cephalometrics, you start to realize how inadequate cephalometric analysis really are. For example, this is a case that was treated by an orthodontic colleague of mine. He chose to what he refers to as develop the arch versus extract teeth. And here's the mechanics he used. And here is what the case looked like 27 months after the braces were installed. When you look at the clinical photos or you look at just the clinical crowns, yes, it's an impressive result. There's no doubt about it. But if you take a little closer look, you start to see a little bit of clefting of the gingival tissue associated with the central incisor, the cuspids, and the first bicuspids. And with these lateral development arch wires, that's where you get your correction. It's usually by flaring out or expanding the intercanine and first bicuspid arch width. When you do use these lateral development or broad formed arch wires, whatever you want to call them, and you expand the intercanine width, the incisors may or may not flare forward. In other words, if the space comes entirely from the intercanine expansion, then the incisors to mandibular plane angle may not change significantly, especially when you look at it from a cephalometric x-ray. So if we look at that patient that had the expansion arch wires, this was his post-treatment cephalometric x-ray. And yes, maybe those lower incisors are a little procumbent, but certainly that's not bad considering what he started with. With all that crowding, you would accept that result based on post-treatment cephalometric x-ray. However, a cephalometric x-ray is not capable of looking at changes on individual teeth, nor changes in the intercanine width. So when you look at this patient's cone beam CT, and this orthodontist took this cone beam CT 3 years post-active orthodontic treatment, and these 3D reconstruction is adjusted to comport with the individual slices. So here is what that patient's post-treatment cone beam CT looked like. And notice that there's dehiscence or generalized dehiscence from the first bicuspid to the first bicuspid on the other side, and that comports with the shape of those arch wires. So when you look at the individual slices of the incisors, you can see here where the interceptal bone is, and you can see how much that lower left lateral incisor was dehisced through that bone. But really, when you look at the cuspids, it tells you more of the story. Because when you look at the cuspid, on this case, you see that they were dehisced about 5 to 6 millimeters. And that's about the change in the intercanine width, which was about 11 millimeters. As orthodontists, we're really not used to looking at cuspids. So when we look at this cuspid up here, we don't know if that's a normal looking cuspid within the alveolar housing or not. So let's compare it to a patient that was untreated with a reasonably well aligned lower arch. So you can see where the slices are being taken here, and you can kind of look and see what the cuspid position looks like for this patient. And as you can see, these cuspids are well within the alveolar housing. And when you compare it to the patient we just discussed, you can see how these cuspids were expanded to accommodate for the lack of room in that lower arch. When I was a resident, we used to take these posterior anterior views and try to trace the buccal segments. I don't know that anyone that still does that, minimal, or I would say of worthless. They were really of no use whatsoever, but we used to do them on our patients thinking we were doing something constructive. So what does that say about the future of orthodontics? Well, I think it's very positive. If you asked orthodontists if cone beam CT will eventually replace cephalometrics in terms of diagnosis and treatment planning our patients, I think 100% of them would say yes. But if you ask them, what is cone beam CT used for, you get a variety of answers. And I think we're starting to see really the true value of cone beam in certain products that are coming available to us as orthodontists. With these new systems, we can actually treatment plan the case using the cone beam CT and the digital scan that are merged together, and we can see the position of not only the clinical crowns, but the roots within the alveolar housing. As you can see in this system here, this is a new lingual system by a company called Brius, but there's several others as well. And I believe that this is the future of orthodontics, and I also believe that it will move orthodontics back into the specialty arena where it belongs. Thanks for listening. If you have any questions, please email me at drmiller@orthodonticassociates.com. Thanks very much. I hope you found this short talk useful.